Hello and welcome to Direct Supply's Continuing Education webinar series. Direct Supply offers monthly webinars on a variety of topics throughout the year. The topic for today is promoting a culture of safety in assisted living, a focus on resident transfers and mobility. My name is Robin Malik and I will be facilitating today's meeting. Please note the information contained in this presentation is intended to provide general information but not advice about certain regulations and initiatives. This is not intended as legal or other advice, and each situation may vary depending on the particular facts and circumstances. You should not act upon this information without first consulting with qualified legal counsel. Today we are joined by Liz Jensen. Liz is the clinical director at Direct Supply. She is a board-certified gerontological nurse with over 25 years of experience in nursing leadership, practice, and education in the post-acute care setting. She specializes in translating evidence-based research, regulations, and risk management strategies into practical process and application for clinicians and frontline care providers. In her current role, she consults with senior living operators and clinicians on process and practice improvements to improve clinical care capabilities that drive positive resident outcomes. And now, please welcome Liz.
Thank you, Robin. Hello, everyone. Welcome today. We're so glad that you were able to join us. As Robin said, I'm Liz Jensen. I'm the clinical director here at Direct Supply. And we are today going to really hone in and focus on talking about some basics of program development around transfers and mobility and promoting a culture of safety, specifically in assisted living. Although if you're practicing and working in a skilled facility or work with skilled providers, I think there'll be some good takeaways for you from this program here as well. So our learning objectives for today, we're going to discuss the opportunities and challenges to consider when building a program like this. We'll look at some of the latest research and best practice resources for promoting a culture of safety, including resident transfers and mobility. And then we'll look at identifying some specific strategies that impact safety by addressing residents' mobility needs, transfer processes, and the environment. So before we get into kind of the program development part of it, I'd like to spend a little bit of time talking about what's at stake here. In my role here at Direct Supply, I get the opportunity to work with hundreds of providers from across the country. If you've not been to Direct Supply before, we're here in Milwaukee, Wisconsin, and we have a large design center and a place where people come from all over to come in and work with our teams here. We provide consultation and help with developing formularies and product development and so forth. In the course of many of those conversations, what we're finding is that, especially in the assisted living communities that we work with, is that we're seeing a real increase in the number of residents who are requiring more assistance with transfers and mobility. And when we talk about really what's at stake here, I think it's important to look at some of this kind of what I call the sobering statistics related to injuries associated with resident mobility. And for many assisted living providers are really coming to terms with this more and more now than they may have ever done so in the past. Whereas maybe hospitals and nursing homes have experienced this for some time and have understood this issue for some time. This is a newer one for some assisted living providers that we're working with. So when we look at, again, just some of these sobering statistics, healthcare workers experience 7 times more musculoskeletal injuries than any other healthcare worker. 20% of nurses today, now this is all information from the U.S. Department of Labor and from OSHA, that says 20% of nurses are leaving the workforce due to injury. In a time and place when we can't afford to have any healthcare workers not working in our space, when we need all the healthcare workers we can get, losing them to injury and something that's preventable is something that we should all be concerned about. And just the costs associated with both direct and indirect costs for back injuries in healthcare workers in the United States is enormous. OSHA estimates it's about $20 billion. And so this is a really significant issue, and one, again, I think that many assisted living providers are just really coming to terms with. So what I share with providers when I meet with them is that you are not alone. We're hearing them share things with us like, I have residents that need help out of bed, out of a chair, or on and off the toilet. My residents need more help than they've ever needed before. or maybe they're moving into my community and they look one way when they move in, and within a few weeks now we're starting to see that they really do have an increased need that we hadn't really identified on admission or move-in. We're hearing folks tell us that they have staff and residents that are sustaining injuries during transfers. We're hearing things like my occupancy is being impacted due to move-outs, or our inability to provide the level of care needed. So as that acuity continues to rise, they're struggling with that. We're hearing providers tell us that they're concerned that their community might be less attractive to potential residents if they see lifting equipment in the hallways. Although I have been probably 3 or 4 conversations in the last few months I've had with providers that have shared with me that family members and residents are actually starting now to ask about that type of equipment as they understand that communities that have access to lifting equipment and that can help them stay in the community longer is more attractive for them as they're continuing to age in place. And so we're starting to see, I think, kind of a shift in belief and feeling about having equipment in the communities. And probably troubling, I think, for sure, is that we're seeing many providers are seeing residents bringing in their own lifts. And we'll talk about that here in a little bit. This is a very unique situation for assisted living, one that we don't see happen in skilled nursing or in hospital settings. So this is a unique issue, and we'll talk more about that here in a little bit. So I like to spend just a little bit of time kind of teeing this up, and if you've heard me talk about the issue of rising acuity and assisted living in the last year or so, you've maybe seen some of this information. But I think it's worth noting that we're continuing to see the average age of residents moving into assisted living for the first time increasing. Even from a period of time, this was a study that was done. It was done by the CDC. It was a national survey of residential care facilities. Over just a 9 to 10 year period of time, we saw the average age of move-ins go from 80 years old up to 87 years old. And the average number of months that those residents are living then in the community is dropping. So they're coming in older, they're living with us for shorter periods of time. And part of that is because they're moving out due to increased care needs that the community just can't meet. I think the other thing of note is that once we start seeing older adults get past the age of 80 or 85, there's a lot of additional, if they've got comorbidities, multiple chronic conditions, we start to see things escalate, and actually the rapid development or decline in their ability to manage their balance and decreases in strength and so forth really start to escalate as we see that age creep. And again, this is just some of that same research from that same study, and you can just see that that gradual increase in people that are needing more help, or that are using a walker, that are using a wheelchair, and so forth. So profile-wise, this still holds true for today. This is from, again, kind of a profile, I think, of most assisted living facilities kind of across the country. Now assisted living operates by different terms and names depending on what state you happen to be in. But in general, 70% of residents living in assisted living today are female. 42% have Alzheimer's or dementia, but I've seen some recent research as of just a couple months ago that is indicating that number is actually increasing. That would certainly bear out, I think, in some of what we're seeing here at Direct Supply as well, and the number of developers that our development team is working with that are adding memory care onto their communities. So I think we're only going to continue to see that number rise. Residents, again, in this average profile, have 2 to 3 chronic conditions and need help with 2 to 3 ADLs. So when we look at the data that's available to us today, this was a 2014 CDC study. This was a bit of updated part of that same study. They estimated there that 26 to 39% of residents need help with transfers, and 25 to 40% need assistance with mobility. Now, this is data from this survey. I could tell you that probably the customers that we work with, that when we talk about this number, many of them will tell us that it's more than this. And so depending on, again, where you're working, what type of community you're operating in, but I think the bottom line here in the story and all of this is that we're seeing older adults aging in place in their assisted living communities that need more and more help with transfers and mobility. So for many providers then that have not really thought about bringing lifts or bringing equipment into their communities, one of the things I think that's important to think about is, and many of them are thinking about this, is how do I build a business case for bringing, buying this equipment and investing this equipment and thinking about what I should be spending. These are just some rough estimates from OSHA. This was from a report, I think 2 or 3 years ago now. But I think that, you know, when you look at the research, that this is right about where we typically see direct care costs associated with workers' comp claims, around $15,000 per claim. And then the indirect costs, which are always harder to measure, which include turnover, training, things like incident investigations, productivity, morale. You take that 15.6 number and you multiply that by 2 to 4 times, and you get your total kind of all-in costs related to injuries related to staff. And that's just staff injuries. This doesn't account for potential injuries that residents may incur from falls or from transfers that haven't gone well for them and have resulted in an injury as well. There's good research and good documentation that the impact can be upwards of 70 to 90% reduction in worker comp claims in hospitals and nursing homes. And I think that as assisted living providers, it's really important to note that and to learn from what our counterparts in the care community are experiencing here. So as we're thinking about building a business case for this, in lieu of having strong evidence in assisted living or strong data in assisted living, it's important to look at how these other care providers are experiencing the benefit of bringing in a better program. All right, so let's talk about what that means to really build a program. This is actually a tool. I've developed a lot of programs over my career, a lot of clinical types of programs, working with skilled nursing and assisted living providers. And this is a format or a process that I have used and followed for years. We have a product advisory board here at Direct Supply that is made up of clinical executives, nurses, and therapists that provide us input on products that we're working on and processes that we're working on. And we ran this by them a couple years ago and got their input on some of these steps as well. And many of them concurred that they were trying to follow similar types of steps when building out a program. And that it's important to have some method to this, because I think that many times we'll see providers come to us because they're in crisis a bit. They've had an influx of injuries. They've had customers that are or residents and their families that are demanding or asking for products. They feel kind of flustered and stuck on how do I solve this problem. Or they get a call from their corporate office that says, hey, listen, your falls and injury rate is pretty high, or your workers' comp claims are high. And so we're oftentimes finding that we're working with people that have already identified that they've got a problem, and in some instances have to go back and correct for some things that have already occurred in their organization. The other thing that makes it, I think, challenging sometimes from a program development perspective, especially in assisted living, is that many assisted living providers are maybe independently owned, or they're part of some smaller organizations that might not have a corporate structure or corporate resources that they can look to say, hey, can you help me build a program? So we're going to talk through some of those pieces today, and my hope is that those folks that are here on the phone or on the line that are in kind of charged with the task of building out a program, this will give you some ideas and some tips for how to do that. So for our purposes today, we're really going to focus on these first 4 squares: program vision, research, development, developing a plan, and acquiring the tools. Once that first part of the program development is done, and as we start to get into the identifying program champions within your organization, which is really critical, implementing the steps and the programs that you're putting into place, and then the ongoing monitoring of that will come once you get your program built. But for our time constraints today, we're going to focus on this first part of the process. So I'd like to just start off a little bit talking about the concept of being a high reliability organization. Now, high reliability organizations are organizations that operate in complex, high hazard areas or situations for extended periods of time, and they do that without sustaining any serious accidents or catastrophic failures. So this was a concept that was first really researched and studied back in the kind of late 80s, early 90s, and started to become well documented, I think, initially and focused on looking at why do some organizations not fail as much as others, and what is it about certain organizations that really set them up for success in the long haul. And the area that we really first saw this concept come out of was the aviation industry, nuclear power plants. Again, and we would hope for that, correct? That we've got a real focus in those organizations on not ever having an error. I just was on an airplane last night, actually, flying back from Austin, Texas, via Tampa, Florida. And we were set to board our plane. We were already standing in line at Southwest and getting ready to board the plane. And they came over the loudspeaker and said, we are having to test one of the engines on this plane because it didn't shut down properly when this plane landed. And we need to run it through its paces and make sure that it's safe. So, everybody's moaning and groaning, great, we're going to be delayed and so forth. And sure enough, a few minutes later, they came back and said, no, we were going to have to ground this plane. We don't feel it's safe to fly. Now, this had been a plane that had just been in the air with a bunch of people in it. And, now it's pulled up to the gate, and they tested it, and they went through their series of checklists and tests, and this particular part of the test didn't pass muster. So they grounded this plane. We ended up being delayed a couple hours, but we were put on another plane. And the confidence that we all need to have when we get on a plane that they're doing those things, that they're testing for those things, is really, really important. And so the concept of applying high reliability organizational concepts into healthcare makes a lot of sense, and a lot of hospitals and healthcare networks have been working on this now for a number of years. This is a concept, I think, that as we continue to provide more complex care in different types of care settings and caring for very frail elderly folks, that this is a really great framework for us to look to and learn from because of the promotion of a culture of safety, creating an opportunity for staff to ask for help where it's safe to ask for help, where it's safe to report incidents, where it's safe to raise your hand and say, listen, I don't feel comfortable lifting this resident, I'm worried that she's going to fall, or I'm worried I'm going to be injured, and that organizations that have these principles of this persistent mindfulness around safety are those that will achieve and be able to sustain a high level of safety going forward as well. So it's just something that I like to talk about and like to share because I think conceptually it's one that as assisted living is taking on more and more of these types of complex clinical care commitments to their residents, it's important to be thoughtful about how we're going to go about doing that. So some other unique things I think to consider in assisted living are obviously state regulations that can vary by state. We work with a lot of multi-state assisted living organizations that can be really challenging for a corporate office to develop and design practices that work in all of the states that they operate in. And so many times it does become a very local or regional approach to these policies and procedures. Licensure, I'll just point out there's three things when you look at your licensure and regulatory requirements within your state, is what does it say about your resident admission requirements related to how much assistance a resident can obtain or needs before they have to move out, their ongoing stay requirements, and what does it say about emergency evacuation? So some states will have, within their rules and laws, will state that a resident might have to be able to independently get themselves out of a building. So if you have moved to a place where now you've got lifts in the facility and a resident actually needs a lift to get out of bed or out of a chair, now you've kind of crossed that line and your inability to provide a service for that resident might be limited and you might not be able to provide that service service anymore. So it's really important to make sure that you're understanding what your state laws and licensure says about that. And then I think it's important to, as a business model, to really ask yourself the question, are you able, does your state regulation and your licensure requirement allow you to, are you able? And are you willing to change the level of care and service that you're delivering? And I think that those are two distinct and important things to ask yourself is, are we able to do provide another level of service, but are we really willing to as well? And we'll often see that willingness to change levels can really vary within even a team in one community. An executive director might think differently than the nursing director, or might think differently than the life safety or the wellness director. So there's different approaches. That commitment to a culture of safety which we just talked about, which includes a strong commitment by leadership and setting a vision and staff education and that ongoing support. And finally, I think some unique things to consider are equipment and storage, and where will you keep this new stuff that you're going to bring into your building? How will you store it? Having accessibility for your staff so they don't have to go up a floor, or, to the other end of the hall or other end of the building in order to get the equipment. So all those things are things that communities have to consider when they're looking at this type of a program. I do just want to touch on, there is regulatory guidance now. Let's see, I think it's 10 states now where we're at today that have actually enacted legislation or adopted regulations around safe resident handling or safe patient handling anywhere care is being delivered. And so if you live in one of these states that are here on the map, I would encourage you to read and understand what those regulations are, maybe review it with your attorney or counsel for your organization, make sure that you understand. And along with that, I think we're seeing these states really commit to developing materials. The quality improvement organizations in many of these states have developed some really amazing educational materials. And if your state hasn't developed great materials, you can look to other states for help that have developed some of those materials as well. So I think we're going to continue to see the move towards more regulation. It seems to be being more widely adopted. Excuse me. In addition, some additional resources to think about for promoting a culture of safety. The American Nurses Association has a really great materials on safe patient handling and mobility. They're focused on interprofessional standards across the care continuum. I think later in the deck here I've got the link or the reference to that where you can find that. If you just Google American Nurses Association, you'll be able to find it as well. The VA actually has done some amazing work. They've got some great materials, assessment tools and documentation tools and educational materials on developing a safe patient handling and mobility program. And the CDC and the National Institute of Occupational Safety and Health also have some really great resources available. I think I was recently talking with Ray Miller, our Director of Risk and Safety, and he was pointing out to me the resources that the state of New York has developed, which are very comprehensive and would be another nice addition, I think, to this list as well. So you're going to all the work to figure out what your program is going to look like and what the kind of the scope and the development of all that needs to look like. And as an assisted living provider, what I would encourage you to think about doing is, as you're building out a program, is thinking about how you'll be measuring outcomes. So we talked earlier about the outcomes of workers' comp claims and incidents and accidents. And certainly those will be key outcomes for you to be looking at and monitoring. But some other ones you might want to think about are outcomes that will be important to be able to share with the community. They might be important to share if you're working in a state or an area where maybe an accountable care organization or an insurance companies want to partner with you to provide more services. Certainly, I know we're hearing assisted living providers tell us that hospitals want to know what their rehospitalization rates are, and they're looking for more outcome data from assisted living. And so this is a perfect program area to think about where you want to be measuring outcomes and how you'll be able to demonstrate that the interventions that you're putting into place are actually effective and working. So 2 areas to think about are resident-related outcomes and staff-related outcomes. The resident-related outcomes, resident satisfaction, and I'm guessing most of you probably do some type of resident satisfaction survey already, and understanding how they feel about bringing more lifting equipment and implementing lifts in your community will be important. Looking at your falls and injury rates, your hospitalization rates, functional status, where you're able to measure. I had a nurse actually just last week. I was at a conference was sharing with me that they've been able to in her assisted living. They've been able to demonstrate that they've been able to improve the functional status of the residents that are being moving in that have memory impairments or cognitive impairments, dementia, and by implementing targeted programs and increasing exercise, finding more ways for them to be active and socially engaged, that they're seeing improvements in their functional status. And part of that has had to do with implementing programs that allow these residents to get up and move and be more functional, and that's included the use of some equipment to do that safely. So I thought that was pretty interesting. Staff outcomes to think about, again, staff satisfaction, accident injury rates, missed days of work, workers' compensation claims, and staff retention and turnover. And as I mentioned earlier, your hospitals and nursing homes have seen significant improvements in all of these metrics when they've implemented a safe resident handling program. And I think it's safe to assume that we would see that in assisted living as well. So as we look at continuing to build out what the program, this programmatic approach looks like, is really defining that program and approach. Remember, what we talked about is what are you capable of and what will you be willing to provide. We're going to talk here now briefly about interprofessional team processes, staff education, resident and family education, and investing in proper equipment. So as we move into this next part of the session here, we're going to cover and talk about the rest of these. So building out your program, I would encourage you to think about establishing a committee within your organization. If you're the director of nursing and you're deciding this is something important and you need to, take this on and you're going to build a program and write policies and get this in place, if you don't have the buy-in from the executive director or the buy-in from the team, the chances that your program will successfully be implemented and be able to be sustained are very limited. This really has to be a team commitment, a team approach, and it needs to start with the leadership. So I would encourage you to, have a conversation with the executive director then in that instance, and perhaps pull the some of your direct line staff into the committee, your wellness director, any of the key decision makers or influencers in your organization that will be able to help with being champions and in implementing and sustaining the program. We talked earlier about clarifying those regulations, your licensure requirements, and the business model. I would encourage you to look at identifying existing programs that are available. We just talked about a few places to look for some good resources, but you might want to check with your current insurance carrier as well, or insurance broker. We've found that there are insurance companies out there that already have some programs around this that they're using or have provided for other organizations that they insure. And so I would encourage you to check with them. They may have some resources for you already available that could really shorten up the process and really help with the building out of your program. I would encourage you to conduct a community assessment. You're going to want to understand what type of assistance your residents currently need today. And I would encourage you to think about what you think your community is going to look like a year from now and beyond. I've never been in a community, I've never worked with a group that's not in some kind of a constant evolution and flux. And the way you look today does not look the same way as you look a year from now, or maybe you looked a year before. So there's constant changes in the types of residents that are moving in and leaving your community. And so I would encourage you to look at where you're at today, but also think about where you think those trends are going and what you think you're going to look like a year or two from now. So as you're planning for how to select and bring in the right equipment, that you're being thoughtful of that. You want to make sure you understand current equipment that's owned by your residents that are living in your community today, and that's really important. Medicare will pay for residents to be able to purchase certain types of lifting devices or powered chairs, for instance. And it's important to understand if that equipment currently exists in some of the apartments in your residence community, and what's being asked of staff in as far as being able to understand how to use that equipment. And then you also want to look at any equipment that's currently owned by your community. And I'd encourage you to, if you're newer to your community, make sure you open up all the closets and you look inside. I've been in some communities where we've had a new executive director that's walked through the building, and he didn't think he had any lifts in his building, but when he started to do a little investigating, discovered he actually had two sit-to-stands, and he didn't even know it. So it's important to make sure that you understand and talk to the folks in your community as well, the maintenance guys, and see if there's anything that's being stored anyplace else. You'll want to think about the environment of where you're going to be using the equipment, and the clearances, but how big the doors are, hallways, and so forth for being able to bring in equipment and where you're going to store it. You also want to think about then as we start to look at what I call really high-risk care tasks. So these are the common tasks that your care providers are probably engaging in with your residents that have some of the highest risk for injuries related to them. So things like transfers from seated to seated or seated to standing, positioning in bed, exiting in and out of a bed or in and out of a chair, bathing, getting in and out of a tub, using a transfer bench or a shower bench, lifting limbs. This is something that a lot of folks don't think about. If you've got somebody that's quite heavy, sometimes a leg or an arm can be quite heavy, and if we're trying to reposition or get somebody comfortable, or do a dressing change or provide pericare, that sort of thing, sometimes using lifts to help lift limbs can be helpful. Transporting residents, weighing residents if we need to get a weight, and helping them with ambulating or walking. Some things to think about when you're looking at assessment then and assessment tools are your residents' capabilities and their needs with transfers and ambulating. I would encourage you to look at your intake form and your assessment form today and think about how that tool is constructed and developed and how it's asking for information. Many assisted living providers still have tools, or their assessment, their intake tools are really designed around identifying and applying a price or a cost to a level of service. And you want to make sure that you've got the right clinical metrics that are part of your intake assessment and your reassessment process to make sure that you're capturing other types of changes that might be impacting a transfer mobility. I've listed a few of them here. I won't read all of those off here. These are certainly all researchable online and some that I think could be nice for adapting or thinking about adapting for use in an assisted living environment. I have not found one standardized tool for assisted living yet. If you've found one and it's research-based and been tested and validated, please let me know. I think as we're continuing to see more and more research done in this space, in this area, I think we'll continue to see that develop. But these are some researched and validated tools to look to. And even if you don't go that route with a formal tool, even just taking your existing tool and looking at, does it include information that I can collect on the resident's ability to listen and follow instructions, and also keep in mind considering different times of the day. So you might be having a conversation with somebody at 9 a.m. in the morning after they've had a night of sleep and a cup of coffee, and they seem, bright and cheery and able to answer all your questions. And then you might see that same person at 4 o'clock in the afternoon or maybe 7 o'clock in the evening, and they're tired. They might start to have some changes in their ability to answer questions consistently or follow instructions consistently. And it's important that you're thinking about that in all times of the day. And it's important, too, that if you're capturing that information from family members in particular, that they are taking that into consideration as well. Because they might say things to you like, oh, mom's great. She's sharp as a tack, and she knows exactly. She'll be able to help you at all times. But they're maybe not seeing mom, at 7 o'clock at night after she's had a full day, has been up and about, and is tired, and is maybe not able to follow directions as closely. So it's important to keep in mind. And that kind of ties into that ability to participate in the transfer then. So for a resident to be able to follow instructions and to be present with the staff member when they're getting ready to do the transfer is important to helping to reduce the risk for an injury during that time. Does your tool look at their ability, the strength to stand and walk? And how far can they walk, and how can they, do they have enough strength to stand and pivot or stand and transition from their bed to a chair, from their chair to the bathroom, and so forth. Many tools that I've seen assisted living providers have some of those basic assessment components that are a part of it, and many nurses will intuitively do that as well when they're doing an intake and wanting to see how somebody safely maneuvers around their apartment and gets in and out of their room. And I might encourage you, if you're only doing that at certain times of the day, that you might want to think about adding another assessment period at another time of the day in order to make sure that you're kind of capturing the whole picture of their dependency. Balance, I think that's part of that same assessment. And then additional considerations, including any visual or hearing impairments, medications that might, just polypharmacy period can increase the risk for falls. But if they're on any blood pressure medications, any diuretics, anything that would have a particularly high incidence of causing dizziness, sleepiness, pain medications, and so forth, you'll want to take extra caution there. Any changes they experience in their blood pressure when they move from one position to the next, orthostatic hypotension that might be impacting their safety, and then urinary urgency. Never underestimate the need to pee, is what I tell people, and that you need to, when you gotta go, you gotta go, and so and there may not be time. Someone might not feel like there's time to wait for somebody to bring in a piece of equipment to help them stand up to get them into the bathroom. And so it does increase the risk for rushing. It increases the risk for injury. So being as anticipatory as possible and understanding someone's urinary patterns and when they typically tend to need to go, paying particular attention to people who are on diuretics and what their pattern is like and when they tend to need to go, and anticipating that in order to try to reduce the risk for injury there. All right, so as you're thinking about then the policies and the procedures and the standards that you're going to need, many times, as a nurse, and I've just written more policies than I care to ever want to count over my career, but that's often our initial go-to move is to say, well, we need a policy for that. Or if we only had a good policy that instructed our staff the step-by-step instructions to follow, that then we wouldn't have this problem anymore. And it's very common to think about applying a policy as a solution to a need for something, especially something like this. I would encourage you to really think about what you need a policy, a procedure, and what could be considered standards of care in your community. And you'll want to have this conversation, obviously, with your attorney and any of your regional or corporate teams that you have here. But many times the need to add a lot of policies can sometimes be detrimental, because if a staff member doesn't follow every single step to the T, can sometimes result in survey issues, and there's all sorts of things like that to consider. So education is important, establishing standards of expectation, standards of care. Some big areas to think about really focusing on and making sure that your staff understand what the expectations are of them are around assessment and reassessment of the resident, emergency evacuation, which you probably have already, and then the use of the safety equipment. So when you expect people to use gait belts, when you expect people to use sit-to-stand and lifting equipment, floor lift equipment, the number of people needed to do assists and so forth. So think about what you think you're going to need and take a thoughtful approach and make sure that you are getting the input of others on your team on the policies and procedures that are needed before you start writing. And then I would encourage you when you look at your interprofessional team then, so this isn't just about the nursing staff or the CNA staff. This is about anybody who might be involved in a transfer in your organization, in your community. So perhaps it's somebody that's on your dining staff that might be helping people maybe from a wheelchair into a chair, or maybe it's somebody on the rehab team. And you've got rehab in the gym, and you want to make sure that the team there has the right equipment and the right resources available. So I would encourage you to look at wherever you think those types of transfers are going to happen. Getting transportation on a van, for instance, if your community offers that to residents, who will be responsible for helping people get on and off and the equipment that they're going to need for that. When we talk about staff engagement and education, I think that there's a couple. Well, there's a lot here, right? And we're not going to have we only have an hour, so we're not going to have a lot of time to really dig into all of this. But I would really encourage you to think about how important it is to emphasize engagement from leadership. And that engaging staff, and going back to that, the concept of a culture of safety and the high reliability organization that encourages reporting of unsafe incidents and encourages people to ask for help and ask for questions, is critical to that staff person feeling comfortable and confident that they can ask for the help that they need. And the only way that works is the only way they'll do that is if it works for them. And so it really needs to be emphasized by the leadership team. Investing in ongoing staff development, I think that the most successful organizations that I've seen that have developed and consistently implemented good safe resident handling programs in their communities at the community level have found champions within their CNA staff who feel passionate about this, who are given the opportunity to provide education to the other care providers, that are giving opportunities to really own this process. They're the staff that are most impacted by this, and finding ways to bring them in and help them be the leaders of this program, so that it's not just a top-down, our boss says we have to do this kind of a mentality, that they're supporting and educating and encouraging each other. And so having leaders that are a part of that group of folks that work in your community is really critical to the ongoing and long-term success of this program. I think it's really important to have hands-on training with the equipment. This is a tactile learning exercise. There's a lot of concepts, I think, that can be taught in a classroom or in a sit-down situation, but nothing beats actually being able to get into the lift themselves, being able to operate the equipment, figure out what it feels like, what it how you feel when you're in it. All of that is really important. And again, having safety champions in your community, people who are your trainers, people who can really own this. So when you have staff turnover, if you've got new people that are coming into your organization, that they can be the champions for that. And I think then as leaders is really to check in early and check in often with the staff on how this is going for them. Helps to elevate and maintain the importance of this to you and the importance to help keep them safe. As you're kind of honing in on your education, I would encourage you then to think about where your really high-risk areas are. And one of those areas is around the issue of exertion. So we're at higher risk for injury when we're exerting ourselves more. That makes sense. There are times and people that we're caring for that can forces a caregiver to exert themselves more. So for instance, someone who's overweight, or if you've got a number of obese residents, people with a cognitive impairment that might be inconsistent or we're not sure how they're going to respond when we get them into the piece of equipment. People that have just a higher level of dependency, I think for different reasons. Someone who's unable or unwilling to actively participate in the lift is going to make it that much more challenging for the transfer of the lift to occur. It's important to think about frequency, the number of times a caregiver performs a task. And this is interesting as you're starting to look at your community assessment, is maybe even ask your caregivers, how many times do you think that you've transferred somebody today? How many times have you done that task of actually helping somebody out of bed into a chair or from a chair back into bed? How many times and the more times we're doing that, the higher it increases our risk for injury. Anytime we've got posture issues around reaching, bending, twisting, and other awkward positions are all really high-risk areas. And again, through practice and education can all be addressed. And then the duration of exposure. So that cumulative exposure to frequent exertion, posture, and load increases our risk. And so all of these together really create these very high-risk areas. And I share this because I think, when you're building a new program and you're taking on something big and new, sometimes it just feels overwhelming because you think, oh my gosh, I have to put this in place for everybody and my entire community and my entire program. Being able to hone in first on really those that are areas that are of higher risk can help to lessen that overall load and burden of thinking about implementation. And it's a great place to start, and then you can move on from there. Some tips I like to share with staff as far as for avoiding risk is the need to assess the resident's ability to participate in the transfer every single time. So it doesn't matter if you've helped that resident, 3 times earlier in the day. The 4th time, if they're tired and they don't feel like helping or they miss the count cue when you're getting ready to do the transfer, it can happen. So every single time, every single lift, it's important that staff are taught that and encouraged and know how to respond to that every single time. Maintaining eye contact with the resident and communicating the process every step of the way. Inspecting equipment before each use every time. Again, looking at slings, looking for fraying, looking for tearing, making sure you have the right size sling and the right sling for the resident. Those are just key things that need to happen with every single transfer, every single time. And then I think importantly, clarifying the service plan, making sure that it's as instructive and as clear as possible so that staff that are coming on after understand what they're expected to do. So let's talk just a little bit about bringing equipment into the equation here. So one important question to ask yourself is, how will equipment make its way into your community? How is it making its way there today? And most providers, I think, would answer the question one of 2 ways. Either they're making the decision to bring the equipment into the community and they're setting the standards, or the residents are bringing it in. And what we're seeing and finding is communities that are seeing more and more residents bringing in their own equipment. What that's resulting in is in a staff member having to maybe learn and understand how to use 4, 5, 6, 7, 8 different types of or pieces of equipment versus the one piece of equipment that you've brought in, that you've been able to successfully train them on and that they understand how to use safely and correctly each and every time. The more variance that you have in equipment in your community, the higher the likelihood that there will be a staff member that won't know how to use that piece of equipment correctly and properly each and every time, and it will increase the risk for injury and a negative outcome. So now this is tricky for assisted living because residents are moving into their apartment. They're managing their own health care. They're coming to you. They may be getting some additional help and services with certain things. So it's important, again, when you talked earlier about your business model and about how you'll be setting up the expectation around how equipment will be brought into the community. And if a resident wants to bring in their own piece of equipment, that there's a process that it maybe has to go through, or there's expectations that perhaps you'll be willing to use it for a short period of time until we can get them comfortable with your piece of equipment. So there's different approaches, I think, and I think it's one that we'll continue to see more providers figuring that part of it out, because it's still kind of new for a lot of providers. Now, there might be some out there that might say, oh, we've been doing that for years. But I can tell you with the number of people that we talk to and see, I think there's still a very new concept about some of this for many AL providers. So as you're bringing equipment into the equation, it's important to ask, how will it be perceived? I mentioned earlier about how some AL providers have been reluctant to bring in equipment in the past because they've heard from their customers or potential people moving into the community that it feels too much like a nursing home, that they don't want to see that type of equipment in their assisted living community. On the flip side of that now, we're starting to see consumers asking for that and understanding and believing that if a community is committed to offering those types of products, that it will increase the opportunity and chance for the person to live there longer because they're going to be able to have more help. So it's just important to ask yourself that. What will be needed? What types of equipment? We're going to talk about that here in just a little bit of what some recommendations might be to think about. The big question, will it be used, is a big one. We've talked to providers that have told us, I've got lifts in my building, but my staff never uses them. So then, you have to ask yourself, well, why? Is it an educational issue? Is it back to the expectations and the culture of the community? And it's important as leaders then to be asking yourself why and will it be used? And what will it cost? In a little bit here, I'm going to turn it over to my partner here, Kari Harbaugh, and she'll talk through some different product ideas and can give you some kind of ballpark ranges around what it costs to bring in some of these pieces of equipment. I think that the bottom line is that I think a lot of providers are seeing that the return on their investment is anywhere between probably 1.5 to 3 years, depending on what they end up purchasing and how much they end up purchasing and how many injuries they had been having before, workers' comp claims they had been having before. So it's kind of just a ballpark. When we talk about resident engagement and education then, so we talked about staff and the importance of engaging staff. I think we can't underestimate the importance of communication. When I was building out these slides, I had like a bunch of words on the slide and lots of different things we have to be talking to our residents about. And the bottom line is that communication, it's all about communication, and it has to be communication has to happen more than just one time. Moving into, many of you know, I know, moving into an assisted living community can be so overwhelming, and there's so much that somebody's having to process with moving into someplace new. So when it comes to expectations around safety and using equipment and introducing them to these new concepts of we're going to be caring for you or providing services for you in this way, just requires a lot of communication. And I think, the same is true as for family members, and especially if you are looking at bringing in your own equipment. And for instance, a family member might not understand what a sit-to-stand lift is, but might understand what a powered lift chair is, or has seen an ad for it on TV and knows that she can go down to the store down the street, to a durable medical equipment store, and get one of those chairs, and Medicare will pay for it. And it's important, I think, to spend some time with family members and talking about the use of equipment, talking about the safe use of equipment, and asking them to include you in those conversations as they're beginning to make some of those decisions. And I would just encourage you to include that in there so that you don't get surprised by, all of a sudden you've got a bunch of equipment in your community and you didn't realize that people were bringing this stuff in. All right, so as providers are looking at some ideas for ways to invest in success, here's just a little grid and a chart to start with. Kari's going to talk more about this here in just a bit, but I would encourage you to think about, on the left-hand column here, some common situations when you're going to be seeing the need for transfers and positioning help. In and out of bed positioning, assist from a seated to a seated or a seated to standing, getting somebody off the floor if they've fallen, bathing and toileting. And some different products to consider there, again, just to have on hand and or to think about having in your community that can really be helpful. OSHA actually has some recommendations for one sit to stand for every 8 to 10 partially weight-bearing residents, and 1 full floor lift for every 8 to 10 non-weight bearing. Again, those are some OSHA recommendations. I think you'll hear from Kari here as well, and what we usually end up talking with providers about is you want to make sure that you've got a sit-to-stand option available, and you'll also need something if someone falls to get them off the floor. And there's some different products that are available that Kari will show you here in a little bit that aren't that traditional big Hoyer lift that we typically tend to see in nursing homes. So in summary, as I kind of wrap up and turn it over to Kari here, again, I would encourage you as you're building out your program to be thinking about that. How is your leadership team really committed to the implementation of this type of program? What will really be the foundations of your program? I would encourage you to look to those resources that I offered earlier. Look for resources that are already developed. Try not to reinvent the wheel as much as you can. There's some great stuff. It's evidence-based and some really nice resources already out there. Getting your team engaged and your residents engaged in this process, and in looking for ways, the right ways to invest in your people, in your processes, and your products. All right. There's some references here, some more information available there. And with that, I'm going to turn it over back to you, Robin.
And now for anyone interested in learning about the products that Direct Supply offers to aid in proper lifting and transfers, we welcome Kari Harbaugh. Kari has worked for Direct Supply for the past 11 years, most recently as product consultant for bed systems, lifting, and bathing solutions. She's responsible for product training for Direct Supply's line of mattresses, bed frames, lifts, and tubs. Kari stays current on long-term care industry trends and regulations and consults with customers to help them make the best product decision for their residents and staff. Please welcome Kari.
Hi, everyone. Thanks, Robin. Today we're going to start by talking about one of the more simple products in our offering, but it means a lot to a resident that is in a dark room and is at risk of falling when they get out of bed because maybe they can't see or they don't want to have to worry about bumping into something. If they have a roommate, maybe they don't want to wake up their roommate. This is just an underbed light that's motion activated, so as soon as they swing their legs over the bed, this soft light will light up the floor, and it puts off a fair amount of light. It is adjustable in how much light comes off, so it's dimmable, and you can also adjust how long the light stays on. So there's no switch that you have to turn it on every night or turn it off. As soon as motion happens, it turns on, and you can leave it on for anywhere from 10 seconds to a minute and allow that resident to safely get either to a light switch or to the bathroom or wherever they're going without being stumbling around in the dark. So that's a really, really popular one that we've seen lately, and pretty low cost. You can get something like this for around $50 or so. Another product that we sell a lot of, and it started, of course, in long-term care, but we're seeing more and more people put these into assisted living buildings as they become more and more aesthetically pleasing, is a more traditional electric bed. So here I can adjust head and knees. Some of the nicer ones you'll see help aid in not having to reposition the resident as much because they'll move the head and knees at the same time. It's something we call auto contour, but if I just move the head up on a bed, a resident over time is going to slide down in bed, and then you have to come back and pull that resident back up. Takes time for staff, not as comfortable for the resident, but if you can get something that's going to move the head and knees at the same time, you're not going to slide as much. Something we're also seeing is beds that go into a chair position. So as we look at ways to aid in standing and transferring, if I can get a resident into a seated position and take all that work out of them trying to sit up on their own, which takes a lot of core muscles, they're more likely to have the energy and the stability to make that transfer safely. You can also use these electric beds for aiding in standing. So if you sit on the edge of the bed, many of these beds go up to about 30 inches high. So similar to how a lift chair would work, seated on the edge of the bed, the resident's holding the remote, and it'll slowly bring them up to a standing position. So it's a great way to help a resident stay a little bit more independent just by getting in and out of bed on their own. We're also we're a partner with Joerns Healthcare, and Joerns did a study a number of years ago now that shows the reduction in possible rollout falls by just having a wider bed. That's one thing that we're really focused on at Direct Supply, is seeing how many people are finding ways, or how many of our vendors can find different ways to mitigate these injuries. And wider beds have really caught on as a great way to do that. And this study helps show why that is. So you see a 50% chance of rolling out of bed just if you're laying in a traditional 35-inch wide bed and you take a half roll. If you bump out to a 39-inch wide bed and you're laying on your back in the middle of the bed, you reduce that rollout risk by 13%. If you bump out to 42 inches wide, which is now the most popular size that we're seeing going into buildings, you reduce your rollout risk by 36%. So over a third of rollout falls can be eliminated just by having a wider bed. So that's been really popular. Electric beds really can range anywhere from about $1,000 to $2,000, depending on all the bells and whistles you need on a bed. For the most part, all you would need to be able to raise someone up, height adjustability, something wide, you can probably get right in the middle of that price range and get a lot of those features that would be very desirable for a resident who's trying to maintain independence. The next one we'll talk about is a fall mat. Fall mats have come a long way. You might be used to seeing those blue tumbling looking mats. As you can see, this one looks great, looks like a throw rug, but of course it's not a throw rug because those would be more of a hazard than anything. This is one version of our mats, but they'll all have a beveled edge. They're only about an inch thick, and it's a very dense foam, but they look more residential. And we've got a variety of colors and fabrics that you can choose from. I believe there's over a dozen colors in this version. This is called our Panacea Protector Deluxe. We see these used not just at the bedside, but a lot of times in an assisted living setting. A community you'll see falls when mom or dad or grandma and grandpa gets up from the love seat. So you can put one right under the love seat. So very good at absorbing impact and mitigating injury in the event that a fall does occur. These next products are all familiar, I'm sure, to everyone. These are products to help promote self-ambulation. So your wheelchairs, your walkers, canes, these are pretty common products that I'm sure you're all using. Making sure, as Liz said, that you're assessing people. Doesn't matter what assessment you use, just making sure that they're being assessed and using the correct product for what that resident really needs. In addition to these, we've got a couple of different products that are going to look a little bit more residential and are made to work with more residential pieces of furniture. So in the top right-hand corner, you'll see the Bed Assist. Great way to just give residents a handle for ingress and egress from bed. Also, you can keep some things nice and close to you without having to lean over bed or try to reach the nightstand or anything like that. At the bottom in the middle there, this woman is utilizing a stand assist. This is really a great product. If you go into any assisted living building or an elderly person's home, a lot of times you'll notice that if they have a couch, the two ends will get used and the middle section will never get used because you can't get up and down from it. This, of course, we're showing here next to an end, but it's got that rolled arm that makes it difficult to egress from. Something like this is adjustable, so it doesn't matter the height of your couch or your chair. You can put it in, adjust it, make sure that it's set for the resident as well as the piece of furniture, and it makes it much easier for someone to get up and down from that piece of furniture because of the handles that are properly placed there. This next one is one of my favorites, and I know Liz had a slide on it earlier. This is called the Riften Tram. One of the reasons I think this is such a neat product is there have not been a lot of changes to lifting products over the years. You've pretty much had either a sit-to-stand device or a floor lift, where this one is really a unique product, and it's designed to do really three things in one. It's designed to be a seated to standing device, so sort of like a sit-to-stand. You could use it for gait training, but you can also use it as a total body lift from one seated position to another seated position. So That's where a lot of sit-to-stand lifts sort of top out at their ability to help residents. Is if you're not weight-bearing, you really shouldn't be using a sit-to-stand lift, whereas something like this can really transition with the needs of the resident from, even if it's day-to-day, they just aren't weight-bearing today, or they had a fall and now they're not weight-bearing for the next couple of weeks. Something like this can assist them through that recovery and then back to mobility using some of the gait transferring, or the gait training abilities of it. This is just another image that'll show all the different potential uses for it. Really, really unique product. I encourage anyone interested to check this out, and I think we've got some product information that we'll be sending the group, and this is one of them. Something like this would be a package price, and it would be with all the components, including a scale and all the straps available, and that would retail for about $5,000 or so. So that one's a little bit more high cost, but it's certainly going to do a lot more for your residents and varying levels of acuity. These next two are certainly more traditional lifts, and these are designed to reduce risk for caregivers and enhance safety and dignity during transfers for the residents. These are the Direct Supply Atlas lifts. They're compact and maneuverable, so they can fit in tight spaces like a bathroom, for example, where you don't have a lot of area to maneuver and you need to get someone on and off of a toilet, or assistance in and off a shower chair or something of that nature. These are great products, affordable. They're going to do what you need and what you're familiar with most likely. The floor lift, of course, is for picking people up off the floor. The sit-to-stand is going to do seated-to-seated transfers or lifts from a seated to a standing position, but you do want to be somewhat weight-bearing, as we mentioned before. There's a variety of slings available for both of these lifts. Please reach out to your account manager for specifics on any type of lifting device that might be best suited for your communities. Something like this, a sit-to-stand, is usually, this particular one is probably around $2,300, but they'll range all the way up to maybe $4,000 or so. This particular floor lift is probably close to about $1,300, but again, you could see a range of all the way up to about maybe $3,000 on a floor lift, just depending on the bells and whistles that are going to come with it. These next products are slide sheets. If you're not familiar with a slide sheet or a repositioning sheet, they're extremely handy. They're great for transfers, for repositioning in bed. If someone falls and you need to move them to a different area, it's a much better way to move someone than just pulling them, because this is going to be much better for their skin, and it's much easier for your staff because they're very, very low friction material that they're made of. They come in a variety of different sizes and materials. Some of them will be single resident use, some of them will be washable. So just take notice of how you're going to use it, and that'll help you determine what style is going to be best. Some of the disposable ones are nice because a staff member can just keep them in their pocket. They fold up really small, and your staff should probably never be without something like this that they can just, whenever that situation occurs, just pull it out of their pocket and use it and be in a much better position for repositioning the resident, and much safer for the staff as well. Something like this will range in price. You can do, a pack of disposable ones anywhere from $35 to $100. Same with launderable ones. They're going to probably be a little bit on the higher side there, but maybe $50 to $100 for a reusable one. And last but not least, this is the Camel lifting cushion. This is another one of a little bit newer product to our offering, but it's quickly becoming a favorite because for residents that fall on the floor, but maybe your community, as Liz mentioned, maybe you're not just ready to have a floor lift hanging out in the hallway, which is understandable. This rolls up into a small duffel bag, and then you have the pump that would sit on the charger, usually in the ED's office. And if a fall does occur, you can go roll this under the resident, and it inflates. So it starts flat, It'll slowly inflate that resident to a seated position, and then you can transfer them from there, either using a sit-to-stand device, something like the Rift-In Tram, or maybe even just a simple gait belt, depending on the resident's abilities. So it's really small, easy to store. The other thing to think about with something like this is a floor lift, usually you want to have about 3 people, 3 staff members to help pick someone up off the floor. A product like the Camel can be used with just 1 staff member. So that comes into play, I think, a lot in assisted living when you talk about a fall that happened during the night. You might not have a lot of staff on hand, so a product like this is really, really ideal. This is going to retail for around $3,000, and when you think about the alternatives out there, it ends up being a really good option, because otherwise a lot of buildings have to call the ambulance service, and maybe you get a couple of freebies in the first part of the year, and then pretty soon you start getting charged, and it can range probably between $1,000 and $2,000 every time you call that non-emergency number to come pick someone up. So certainly some great products to think about, and with that, I will turn it over to Robin.
Thank you for attending today's webinar. For more information about upcoming webinars, visit directsupply.com/webinars. To see the latest content from Direct Supply, be sure to click on the logo in the upper corner to subscribe to our channel, or click on the link in the lower right to see our entire education and training video series. Thanks for watching and have a great day.